A diagnosis of osteoporosis strikes fear into the hearts of many that receive it. So many are told that osteoporosis cannot be reversed and the drugs are the only option. You need to wrap yourself in bubble wrap and consider your life changed forever. I'm sorry, but that's garbage. I hear this all the time, and it's aggravating. People question me when I say osteoporosis is reversible. It's so clear to me that for so many women and men, bone health can be improved. And by definition, osteoporosis can be reversed. It's simply a bone metabolism issue. I'll show you a case today that not only demonstrates that osteoporosis can be reversed, and we have lots of those, but in this case, it was actually reversed in as little as 6 months. Let me walk you through how we did it. And if you have reversed osteoporosis, I want to hear your story. Leave us a comment and tell us how you did it, what you think the most important variables were. I love hearing these stories. Additionally, the more success stories the audience hears, the easier it will be for them to gain the confidence that they need to move forward on their own path and do it in a safe way so that they can improve bone health on their own. All right, so let me introduce you to one of my favorite patients. We'll call him Bob. Bob's a 63-year-old retired attorney. He did his first DEXA scan in 2022. So this was a couple years ago, and he was a little under 63 at the time. And he was diagnosed, according to his doctor, with quote unquote severe osteoporosis. Now, he didn't even know what that meant. And when we went back and looked at his scans, they were told that he was near negative 3.0. His doctor wouldn't actually give him his DEXA report and recommended a bisphosphonate drug. Wouldn't give him the information and just said, here, take the drug. Now, Bob is not a normal patient. Bob is an avid researcher. And like many of you, rejected the idea that drugs were required and certainly the only option. Bob is an otherwise healthy guy, or at least so he thought. When we create comprehensive programs, we can uncover a lot of things sometimes to work on. But the good news is that when we do this through that lens of health span, through that lens of what else is going on to at least get to the root of osteoporosis, but also to the root of how to help you feel better and live better, we can come up with a number of things that could potentially be treated, which is not necessarily a bad thing. Sometimes we have to ignore some of those things and move on with our primary goals, which is generally going to be in this population, bone health. Some of you might be wondering why I would choose to present a case about a man instead of a woman. And indeed, most of our patients are women. But I am using this as an example because Bob is one of these guys that doesn't really pay attention to all of my recommendations. And I don't actually recommend that people get repeat imaging studies at 6 months because I find that it generally is going to take more like 12 months, and that's what we see regularly. So he wanted a repeat imaging every 4 to 6 months. I said, hey, you might actually not want to do that because you might actually find that you're going to be frustrated with your progress because you're not going to see improvement on imaging. And in fact, you might actually see it get worse before it gets better. But I think Bob is a great example of how a comprehensive program can work that is agnostic to gender. So we are going to move forward with this. And if you want to look at his original scores, let's take a look at this now. All right. So when we look at his initial DEXA score, the initial DEXA report, he did finally get from his doctor. Again, he's an attorney, so he was able to demonstrate to the provider that that is actually his legal right, and it is. So your doctor should always be able to provide you with your chart information. It is actually your property. So if you look at his DEXA said that he had a T-score from anywhere from negative 2.5 to negative 2.9. Now, the negative 2.9 was just one area of his right femur. And it was a small area of his femur. And the rest of it was more like negative 2.5. And so it's challenging as a physician to try to understand what risk is. And I see some physicians doing this. And I think this is the wrong thing to do, which is instead of looking at specifically the femoral neck or specifically the combination of L1 through 4 of the spine, they'll just pick the worst reading and go off of that. So his doctor said, hey, you have a T-score of almost negative 3. This is severe osteoporosis and you need a drug. But the rest of his scores were not that. In fact, actually, when you look at the data, because there's one of those reports that just spits it all out, around the neck, it was actually negative 2.3, which is actually not even osteoporosis, right? The average, though, was a little bit over negative 2.5, and I'll show you that later. So the challenge I have with this is that if you don't know what your DEXA report looks like, and if you don't know what all of the scores are, then I would encourage you to get that information to learn more about what's going on with your skeleton and how the DEXA is reading it. If they're just picking out an outlier and making it look worse, I have a hard time believing that they're not doing that either because they have a lot of fear around fracture, which is possible, or just because they want to try to find a reason to offer you a solution like a drug. I want to give people the benefit of the doubt, but sometimes in some of these cases, I find it's really difficult. Okay, so a little bit more about Bob. So Bob, like I said, is 63. Some important points about his medical history. Bob has a history of acid reflux, or GERD. He has been on a proton pump inhibitor for as long as he can remember, which is not a good sign. So probably at least 10, 20 or more years. Now, Bob also recently lost some weight. And when people lose weight, a lot of times they don't have acid reflux anymore. And indeed, his GERD had gotten better. So that was definitely going to be a target of getting rid of the PPI because I don't think he needs it anymore. He also has a history of BPH, or benign prostatic hypertrophy, big prostate. Not a problem for women so much, but for men, this can become an issue when you start talking about hormone health. He also had a history of looking at some imaging of the heart. So I do this down the road anyway, but he had already done some of this stuff, and we knew that he had a history of coronary artery disease, which is also going to play a role in our recommendations. He has a history of back pain with some degenerative disc disease, and he has a history of a lot of stress. But like I said, he's recently retired. So maybe that's something that we could potentially do something about. Now, Bob wanted to do all the things, and we don't always get genetics on patients, but when we can, we do, because genetics can help us to create a program that is more comprehensive and customized. So for Bob, we looked at some genetics, like particularly this thing called ApoE, which is a polymorphism or a SNP that can change the way that you tolerate saturated fat specifically. Now, he fortunately had the SNP that allows him to do well with saturated fat from a dietary perspective. So he was able to be more tolerant of that. Other significant SNPs that we found in his genetics, he needed support from a methylation perspective, from a B vitamin perspective. He also has issues genetically with vitamin A conversion. So getting a more plant-based diet and consuming beta carotene, trying to convert that to retinol for him would not work very well. He would be retinol deficient, as we were able to see in his labs. He also has a high propensity for vitamin E inflammation, specifically from the one version of vitamin E that is most commonly found in supplementation, which is alpha tocopherol. So there's a genetic SNP for that. And if you have this SNP and you take vitamin E, you could potentially find yourself in an inflamed state rather than getting the antioxidant benefits of vitamin E. So that's also an important one to know, to make sure that he's getting the right forms of the specific vitamins that he needs. And then we did some functional testing. So the first test that we do on most people, we did on Bob as well. So we did a GI effects test, and this is a stool test. Good for Bob, but not common actually, is that most people we see with osteoporosis have some kind of function dysfunction, meaning that they're not making certain enzymes, low stomach acid, et cetera. But Bob's stomach acid and enzymes were great. So that's fantastic. He did have some microbiome issues. He needed some metabolic support. So we were able to create a comprehensive program around that. He also had a parasite that we did end up treating, and that could have been causing some gut inflammation as well. Another thing that we did is what's called a diurnal cortisol. Now, this is a guy who claims to have high stress, and of course, I believe him that he has high stress. And so for people that have high stress, what I want to know is, are your adrenal glands in overdrive, or are they just flatlined, meaning that you've killed them and you have severe adrenal fatigue? And so we wanted to learn this for Bob, which case are you in? And fortunately, Bob, he had some stage 2 dysfunction. So this is something that he's still making cortisol. It's just a little dysfunctional. So we were able to wrap that into the program as well. And then we got our comprehensive lab panel. Now, the lab panel is technically all we need to get started, but you can see how it starts stacking all of these things and you can create a really comprehensive program. Although when you do it like Bob did it, sometimes it's too many things. And so a lot of people just want to start with the labs, just start basic. That's totally fine too. The more we know, the more we can do, but the more we do, the more people can be overwhelmed. So it is a double-edged sword there. So for Bob's labs, we were able to plug his numbers into our scorecard. Now, our scorecard is a way to kind of objectively follow people and their progress over time based off of the biomarkers themselves. In his scorecard, his score number was 58%. Now, that is not an uncommon starting point, but it's not a great starting point. And so you'll see how this improves over time. From a lab perspective, his thyroid was a little sluggish, which is pretty common after weight loss. But overall, his metabolic markers look great. His homocysteine, which is a biomarker that is associated with cardiovascular disease, dementia, and osteoporosis, was a little elevated. Cardiovascular risk, a little bit elevated, and we know he already had disease. He had a history of liver dysfunction, and it was called NASH, or non-alcoholic steatohepatitis. And that had resolved. And now his kidneys look great. His liver looked great. And then we got to his hormones. Now, Bob's hormone story is kind of interesting. So when we started, his total was kind of in the mid 500s. DHEA, which is the precursor hormone to testosterone, was pretty low. His free T was, kind of like lowish normal. And his SHBG, which is the binding globulin for testosterone, that was kind of high-ish. And so he had reasonable testosterone, not great. And his free T was a little bit low because it was all bound up on that binding globulin. So that was certainly something we would address. And then his omega-3 to 6 ratio was low. He needed some omega-3 supplementation. And then all of his nutrients, D, B12, RBC, zinc, RBC, mag, RBC, folate, et cetera, they were pretty much all low. So he had some nutrient deficiencies that we needed to address. And then finally, we get to our bone biomarkers. All of those things, right, before we get to the bone turnover markers. So when we look at his bone turnover markers, his CTX was 494, P1NP 37. The ratio of P1NP over CTX then was 75. And if you haven't watched my video on that, the way that you do that calculation is P1NP 37 over CTX divided by 1,000, so 0.494, and then you get the ratio of 75. That's a low ratio, which means that he's not turning over bone very quickly, although with the CTX almost 500, he is losing bone. So this is not a great starting point for his bone. We definitely had work to do. And then his IGF-1, which is the kind of anabolic catabolic switch is how I call it, was 117, which is low-ish as well. So he had just been on a weight loss journey, so it's not surprising. So he's been breaking down, potentially also why his CTX was a little bit higher as well. All right. So then we go on our journey together. So he gets onboarded, he's chatting with his coach, and we create a program based off of our 4R method. And the first R of the 4R method is to recognize. So why did he have bone loss to begin with? Well, when you look at his numbers, I think that his testosterone probably played a role. His DHEA being low probably played a role. Adrenal dysfunction, stress played a role. I didn't talk about it, but he has sleep dysfunction. He wasn't sleeping well, so that certainly could play a role. He was on a PPI for GERD, which tells me not so much that he had GERD, but that he had gut dysfunction. And so gut dysfunction can certainly lead to malabsorption, not getting enough nutrients, potentially inflammation, et cetera. So the fact that he had GERD tells me that he has gut dysfunction, and certainly that could have been a cause of it. He, prior to his weight loss journey, was relatively obese, so that's going to provoke some chronic inflammation. And then he wasn't really stimulating bone growth because he had chronic back pain. And we see this all the time with people that have back pain. They don't load their back, and their back gets more and more osteopenic or osteoporotic. So I think that and also he had nutrient deficiencies. All right, so you start to stack all those things together, and you can come up with a plan. So we did that, and we set him on his way. And I'm going to go over that in just a minute. But before I do, if this is all really confusing for you and you're trying to come up with a way to do this on your own, consider joining our free Bone Health Masterclass. So if you look if you're on YouTube, the description, there'll be a link for the free masterclass. You can register for that. And then if you're listening to this on a podcast, just go to our website, optimalhumanhealth.com, and you can find all of our resources there as well. All right, so back to Bob. So what did we do for Bob? Well, we always want to set up our programs through the framework of our health optimization triangle or pyramid. The base of that is basically driven from lifestyle. And so we wanted Bob to figure out how to load the spine. Now, we have a program for that. And he also worked with somebody locally to try to figure out, okay, with my back pain, how can I load my spine? And we were able to come up with some ways. Also doing some resistance training for muscle elsewhere. We wanted to increase his protein and actually increase his calories because he was pretty calorie restricted from his weight loss journey. We worked with him on stress. We worked with him on sleep, and that was all driven by coaching. And then we created a supplement stack that included lots of stuff, but some things to point out would be adaptogens for cortisol, thyroid support, but not replacement. We wanted to support his heart health with mitochondrial support because he was on a statin. And then we wanted to treat his gut, and we did that through a specific gut health program. We gave him some glutathione for some inflammation, as well as omega-3, methylated B vitamins, and then supplements to support testosterone as well as DHEA. Some magnesium, a fat-soluble vitamin, Algacal Plus. From a testosterone perspective, he did have some symptoms and he had lowish free T, but he wasn't interested in going on replacement. He wanted to try a lifestyle, a reduction in stress and supplements first, so that's totally fine. He also wasn't interested in working on his IGF-1, even though that was relatively low. He wanted to do this all through diet, which is also totally fine. Some levers that we can hold for later. Okay, so what happened? Well, at the 6-month follow-up, his bone health scorecard went from that mid-50s to 76%, meaning that a lot of his biomarkers are looking better, but we still have work to do. His thyroid was still a little bit sluggish, and this is pretty common, but overall, his metabolic markers still look good. Homocysteine was improved. His cardiovascular risk was unchanged. Again, liver, kidneys, all look good. Testosterone wasn't looking as good, although his total still remained to be relatively, fine-ish, but his free T was even lower. So free testosterone was even lower. He increased his omega-3 to 6 ratio. His nutrients were optimized. And then his CTX had dropped from where it was initially, almost 500, down to 151, which is pretty awesome. So now he's no longer rapidly turning over bone, but his P1P came down a little bit too. And we see that, again, you've probably heard me talk about this, where CTX and P1P go together. Bone metabolism is generally going to be linked, although it's, I would love for it not to be. But his ratio went from, that under 100 to almost 200 at 185. So certainly that's a lot better. And his IGF-1 did go up to 188. So again, he's improving on his own naturally without having to use peptides for that. So again, against my advice, he repeated a REMS. Now, I didn't talk to you about his initial REMS, but his initial REMS showed that he had in the spine together, L1 through 4, a negative 2.6, femoral neck, negative 2.7. So he does have osteoporosis by definition on both DEXA and REMS. And at his 6-month mark, he went from negative 2.6 in the spine to negative 2.4. Same thing, femoral neck, negative 2.7 to negative 2.4. So great. So you could argue that technically his osteoporosis is reversed. Now, are we throwing a party and saying that we're done? No, not at all, because he's right on the cusp of osteoporosis, right? So we definitely still want to keep going in that direction. And I see this mistake not infrequently where people will kind of celebrate too early and let their foot off the gas. And then, of course, it just backslides back to where it came from. You could also argue, too, that percentage of change is not that big, although it's kind of big. And you could say, well, it's within the margin of error of the scan and, you didn't actually make any progress. I would argue that it is the right direction either way. And even if we held it steady, that's still a win, right? Because bone loss generally happens 1% to 2% per year. So, we didn't see a loss of bone. I would think that with those kinds of numbers, that is probably somewhat real. Again, there's really no way to know. So the 6-month mark, we updated his program, did some supplement tweaks. We discussed again, okay, how do we load your spine? Still struggling with that with some back pain. And we added more, physical impact, talked more about lifestyle, and his gut now is feeling pretty good. So then fast forward another 6 months. So now at the 12-month mark, so now his spine is at negative 2.3 and his hip is at negative 2.2. So is that still within the margin of error? Not at all. Meaning that his REMS increased BMD or demonstrated an increase in BMD by 11% at the hip and 4% of the spine. Now, again, his spine was slower than the hip because he's not loading it as much as he potentially could, still dealing with a little bit of back pain, which is common, and that's okay. We deal with what we have. But if you look at fracture risk reduction, which of course is what ultimately we care about, his fracture risk was reduced on fracs by 61% in his hip and almost 40% in his spine. So now at the 12-month mark, he feels like, gosh, I'm still not done yet. I actually want to continue on. So we, get a new set of labs. Looks like his testosterone continues to decline. So now we're going to use a drug that can help to increase his testosterone, not quite replace it yet. My guess is that we'll likely end up replacing it. His free testosterone is now less than 10, so he has single-digit free testosterone. So my guess is he's going to feel really good on that, and we're going to end up replacing it eventually. He's a perfect candidate for that. His bone ratio is still looking good, although his P1P is only climbing slowly. I think it's because his free testosterone is less than 10. So when that happens, he's not getting much estrogen and he doesn't have much testosterone. So in my opinion, he needs more IGF-1, potentially peptides to drive up IGF-1, more protein, more calories. And now we're also looking at this a little bit more from a health span perspective. We're working on cardiovascular risk factors, metabolic markers. So ultimately, with his program over the course of a year, what did we do? Well, we reversed his osteoporosis, right? We're going to continue to work on hormone health. His metabolic health continues to be awesome after his weight loss journey. He's gained a little bit of weight, but mostly through muscle, which is always our goal. We've improved his cardiovascular risk. He's worried about a family history of dementia, which I didn't talk about, but we addressed. We've corrected nutrient deficiencies. We've improved his gut. We've resolved his GERD, or his weight loss resolved his GERD, but we took him off his PPI. Addressed his lifestyle, addressed his stress, and we have optimized his diet. So we kept going. There's more that I could talk about, but I'll cut this off here. But I wanted to give you this case because I want to demonstrate that this is how optimal bone health is achieved. And you could call it reversing osteoporosis, but ultimately we're just improving the metabolism of bone. I feel like poor metabolism of bone loss, osteoporosis, is really a sign of underlying dysfunction that is likely affecting other things too. So if you can address that, then you can address bone health and everything else. There is a time and a place for drugs, and I want to reiterate that. some people are in a situation where they can't do all the things that we did with Bob. And that is not something to feel shame about. It is okay to take drugs if drugs are the right thing for certain people. But if you have the capacity and you're willing to invest your time and your resources, bone health can be improved naturally in most people. And I see that again, time and time again, day after day in our clinic at Optimal Human Health. This was a review of how we like to build programs to reverse osteoporosis. And if you liked this content, consider this video on estrogen. Estrogen plays a big role, particularly in women, but also in men, but only through the source of testosterone. And also there's a video on supplements if you want to learn kind of what learned while we were working with Bob. Here's the updated supplement video on the best calcium source that we like to recommend. And then finally, just remember that osteoporosis isn't the end, but deciding to reverse it is a beginning. A couple of announcements. If you haven't already subscribed to this channel, please do so. If you've already done the masterclass and you're looking for other things to help you on your bone journey, consider our free Bone Foundations course. That Bone Foundations course can be accessed either in the link below or at optimalhumanhealth.com if you're listening to this on a podcast. I'll see you next time.